Hello, everybody, and welcome to today's Center webinar. I hope that everyone is staying safe and healthy, and thanks again for joining us. My name is Paul Lewis, the Vice President of Policy here at the Center. I'm going to be moderating the webinar today on the role of transportation in improving America's health. As everyone knows, transportation access is one of the fundamental objectives of the public sector as a means to provide access to jobs, services, recreation, and other elements of the economy. It's also one of the most important ways the government can enable residents to live healthy and productive lives. And today we're going to talk with the author of ENO's most recent paper, which is Increasing Access to Essential Health Functions, the Role of Transportation in Improving America's Health. Renee Autumn Ray joins us to discuss the paper and her recommendations on how public sector agencies can work together to improve public policy and programming, provide a more equitable environment, and enable better health outcomes that can drive higher qualities of life. Renee Autumn Ray is an urban planner who has worked in transportation and public health planning, policy, operations, data evaluation. She focuses on reducing barriers to access for vulnerable populations, and she currently leads innovation and strategy for Conduent Transportation, a technology company which includes payment processing, enforcement, and data analytics for transit, curbside management, road user charging, and public safety. Renee also serves on the board of directors for Georgia Bikes and on the Transportation Research Board committees for intelligent transportation systems and innovative public transport services and technologies. So obviously a lot of experience in this field, and we're very much looking forward to the conversation. A quick note on format. So we've scheduled this webinar for the next 45 minutes, and we're going to follow a fireside chat format. So I'm going to plan to ask Renee some questions about the paper, its genesis, its recommendations, and then we're going to take some questions from the participants. So if you have a question at any time during the webinar, please submit that via the questions function on the GoToWebinar control panel. I'm going to then take those questions and ask them directly to Renee later in this hour. And for everyone on the line, the slides and a recording will be available on, or I'm sorry, there's no slides, but the recording of this will be available on ENO's website following this. So with that, I'm going to turn it over to Renee and kind of pitch it off by saying, what inspired you to write this paper?
Great. Thanks for the question, Paul, and thanks so much for having me this afternoon and allowing me to publish this paper through the ENO Center. Certainly it was the emergence of COVID-19 and thinking about what I had learned over the past decade or more working both in transportation and health. And we've talked for a long time about the sort of systemic changes that need to happen in the transportation industry and also in the way that we prioritize public health and think about how we pay for healthcare. And my hope is that as we work through this pandemic and all of the many terrible outcomes that we're seeing, both in terms of the health of the population and the economic cuts that are going to be happening in the public sector, that we actually make a lot of the changes that we've been talking about for a long time. So that was really the immediate reason. And I felt as though I had gotten some pretty unique experiences because I have worked in local government for a regional planning agency. I've been a contractor for CDC and federal highways. And so I've worked in both actually writing policy and regulations and actually helping to deliver transportation services to older adults and people with disabilities. And I felt that I had gotten a lot of unique perspectives by being the only land use planner, embedded in a group of social workers at an area agency on aging, or working with a bunch of people that had been administering Medicaid services for decades. And there was a lot that I learned in every job that I had. And so in some ways, some of this paper are the things that I wish I had known when I was starting out that would have helped me do my job better, in addition to the recommendations that kind of come at the end.
Got it. So you're looking at your past self when you're writing this. who else do you hope picks up this paper and learns from it? Who's kind of your target audience, and what do you hope that them and others on the phone listening in and whatnot, what do you hope they get out of reading the paper?
My hope is that it has a pretty broad audience. Certainly, folks come to Eno from all walks of transportation practice and research. I have recommendations for the federal agencies, for state, local, and regional agencies. But I also feel we have an increasing number of people that are getting joint degrees in planning and public health or in engineering and public health. And I think we're starting to see a lot more people working across different sectors the way I've done. And you find a lot of gaps in your training when you start to do that. So my hope with that is that there are a lot of public practitioners, consulting firms, folks that are actually helping these public agencies do the work, but also some more non-traditional people. So people who might actually be administering, Medicaid services or non-emergency medical transportation and are interested in some of the more policy or historic-based parts of the paper.
Got it. Yeah. So for those on the phone and those listening in the recording, you can download the paper. There's a lot of really good information in there and a bunch of recommendations that Renee has put on in the end. Can you talk, Renee, a little bit about what some of those recommendations are broadly and specifically, and really kind of getting at what are some of the gaps that you wanted to address in this paper?
Sure, absolutely. I'd say one of the primary recommendations is to think about and implement a health and all policies focus. So this really makes sense, I think, to a lot of agencies because pretty much every public agency at the bottom has a foundational principle to administer for the health, safety, and welfare of all of the people in their jurisdiction. So, health is kind of embedded, at least at some level, in a lot of the work of transportation and other public agencies. And the goal of health and all policies is to apply a lens of more holistic thinking about what does it really mean to do health if we're talking about, redeveloping an arterial road or, going about the regular practice of our work. When health may not be front and center, maybe we're thinking about something like traffic safety, but we're not thinking more about how is access health related for someone that needs a crosswalk or, an ADA accessible curb cut. So it's applying a more holistic lens to the practice of actually going about the business of distributing services and doing planning and capital projects on behalf of citizens.
Got it. So, the health and all policies concept, I think, is one that rings true to a lot of people, right? I mean, we should be thinking about health whenever we're making any public policy change. Transportation is a big part of that, but it's kind of been slow to take up, and it's more of a recent trend. What do you see as some of the biggest challenges in addressing the linkages between transportation and health in the future, specifically as it relates to transportation?
I mean, I think an immediate challenge is just the fact that it's difficult right now to think about anything but COVID response. What does my budget look like? What does today look like? Do I have real-time information on what's happening in terms of travel behavior in my community? I think we're going to be significantly challenged in the immediate and near term, potentially even the medium term, to think about this pandemic and understand it and what the outcomes are. I don't want to say that there's any sort of silver lining or opportunity because this is such a horrible thing to happen to our country. But it may be that we are forced into thinking more creatively than we have been previously about how can we do our jobs with fewer resources or by doing them in different ways. And I believe that having some relationships and some collaboration across agencies is one of the best ways to actually do that sort of thinking and get things done. Health and all policies is kind of a newer concept. There are some really good materials that are referenced in the paper that give some examples of case studies from both states that have implemented this, and it can be everything from lead reduction in drinking water to things that are a little more transportation focused, like complete streets and how you plan better for pedestrian safety and not just thinking about reducing traffic crashes. So it's going to be so challenging to get out of the situation that we're in now with COVID, but I think that a lot of it is building relationships and thinking more creatively about how to do our work and who are some non-traditional partners that can help us do our jobs better.
Got it. And you mentioned non-traditional partners. In your recommendations, you also mention agencies like USDA, VA. How do these relate to this issue, right? Transportation and health, and these recommendations relate to those agencies and transportation agencies within them?
Sure. I actually think that USDA is one of the biggest, if not the biggest, success stories in terms of a public agency being nimble in its response to COVID. And that when we think about transportation, we're not just thinking about origin and destination or the safety or the condition of a particular part of the built environment, but we're thinking about what is the purpose of the trip, how challenging is it for individual people to take, and are there other solutions to taking that trip besides the cost or the time or the access burden to doing it. So in the example of USDA, food is probably one of the errands that we run the most after work and school. And so when this pandemic hit and you had millions of people attempting to shelter in place, USDA very quickly allowed changes in the rules for people that use subsidized food benefits so that they were able to use those benefits for both curbside pickup or home delivery of their groceries. And reducing those burdens by allowing people to use those benefits in a new and innovative way, I think was something that made a tremendous impact on quality of life and on reducing, worry and concern about both the safety of being in the grocery and just, if I can't leave the house, can I get food? And I think that sort of solution is something that is really compelling, and I think it's something that really helped in terms of people's travel behavior. And it's probably not something that a lot of us on the transportation planning or program side might have been thinking about. You mentioned the Veterans Administration as well. This has been a really interesting program. The VA started a transportation service several years ago, and there's not as much information about that as there is about some of the more traditional programs, certainly public transit, but also the Medicaid non-emergency medical transportation benefit. And in a pretty quick period of time, the VA is now spending just under $1 billion a year on this transportation service. But as much as I could find out, reading online and talking to folks I knew, there's not a lot of information about what is the service, is it being coordinated with other subsidized transportation, are there opportunities to perform it better or to have shared trips? And so it's not something that we normally think of in the transportation space, but it's actually become a pretty significant funder of subsidized trips for veterans.
Got it. So I'm going to turn to some questions. We've already had a bunch coming in. I want to make sure we have time in the next half an hour to get to a lot of them. Again, for folks that are tuned into the live webinar, please submit questions via the questions function on the GoTo webinar control panel. I'm going to try to get through as many of these as I can. So one of the questions we have, one of the first ones came in, talks about your report and the emphasis on what they are calling specialized transit and health issues and outcomes, which I think refers to the kind of paratransit type examples. But the question is wondering what recommendations you might make for reflecting health outcome perspectives in the traditional fixed route transit network that's already in place and in service. Does there need to be a bigger emphasis on frequency or speed or reliability, accessibility? I mean, how do we project some of these same lessons onto the fixed route transit network that already exists?
Okay, I think I'm understanding this question. I'm going to answer, I think, a couple of different pieces. First, I definitely had a focus on specialized transportation. One of the things that I've learned that's been most useful to me is a kind of a slogan from the disability justice movement, which is nothing about us without us, incorporating the people with barriers in the work that we're doing. And when we focus on the most vulnerable users, we come up with solutions that work for everybody. So that's one of the reasons why this was a big focus of my paper, was on making sure that the largest access barriers are addressed, because that creates a system that everyone benefits from. In terms of health outcomes, one of the things that surprised me the most when I came from public health to transportation was how little information we had on travel behavior, why people act the way they do, what are the unmet needs from the different modes that are available. And it's very hard to get that information. You know, we've got the National Household Travel Survey, but I was kind of used to annual surveys about behavior that were done every year at every geographic level and could be analyzed in a number of different ways. Personally, this is going to be a smaller example. It's not a national example, but there was a very fascinating research study that was done here in Atlanta, which was figuring out, can we show a positive health outcome by giving people better access to MARTA fixed route? And what we did was use a 4-question survey tool from CDC so that we had a very strong evidence base that we could analyze in a number of different ways. So we had a population of about 100 people that received a benefit, and we asked 4 questions before they ever got the benefit, about a month into the program, and then at the end of the program. And even with a pretty small sample size, we were able to show a statistical difference that the transit access benefit had a measurable health outcome in this population. So, you know, I think it's going to be it's always hard to quantify health outcomes. And I think that taking advantage of existing data sets and survey tools is going to be the easiest way to try to figure that out when we have so few data standards and sets of data on the transportation side that we can use to quantify that. I'm not sure that answers the question, but I can certainly follow up with that paper from that study if useful.
Got it. No, that's great. A couple questions about the subject of mental health and transportation. One commenter talks about how the act of driving can be very stressful, and so can biking if the situation isn't, you know, safe for the biker, or those kind of things. What emphasis should we have on health and transportation, the nexus of mental health related particularly to stress in transportation?
I'm really fascinated by this topic. I don't know that there's as good data on mental health around mode choice as there may be for some other topics, but I absolutely agree. I think there was like a study of 300 different activities, and commuting was like number 297 out of the 300 in terms of what people find pleasurable. One thing that I think is important to think about is the effects of those stresses. So the barrier of commute time on low-income populations as folks are getting pushed away from city centers and poverty is becoming more suburbanized. I think we're seeing longer commute times, and that affects both, you know, whether people can still work 2 jobs, how much time they have for quality of life activities like spending time with family, and their access to things like being able to grocery shop and cook. I don't think we have great metrics to fully understand that. I think we have to infer a lot and make assumptions based on some other existing data sets. But I absolutely agree that it is important. And one of the things that really struck me when scooters kind of came on the scene suddenly in like 2017 or 2018 was I felt that one of the reasons that they were so popular is because they are fun to ride. And we don't think enough about transportation as something that could be pleasurable. Like I personally love bike riding instead of just, a chore that we must endure in order to get to our destination.
Got it. A couple questions I have here about the partnering with specifically healthcare providers, hospitals, and other providers. Do you see facilities like hospitals becoming more involved and forming new relationships with transportation infrastructure organizations beyond the use of ambulances and other emergency vehicles, and kind of making sure that there is the kind of access to those facilities that should be?
I do, absolutely. One of the things that's interesting about working in this field is how a very small rule change can have dramatic effects on an entire industry. So for instance, telehealth is now become an explosive industry within healthcare because there was a change to Medicare and Medicaid to allow it to be reimbursable. So there was a similar, very small rule change in 2017 to something called the anti-kickback statute. And what that did was allow healthcare providers to pay for transportation for people that had Medicare Advantage. That's the piece of Medicare that is administered by private insurers such as United Healthcare or Cigna. And that led to an extremely significant disruption with primarily Uber and Lyft and some other medical-focused transportation startups contracting directly either with insurers or with healthcare facilities, because there's been pretty long-standing research on how significant a missed appointment is, both on the schedule of the individual provider as well as, potentially exacerbating healthcare conditions and things. So you saw a lot of pent-up demand for that healthcare transportation. There aren't really good reports out yet. There's just one-offs here and there by individual healthcare facilities, but healthcare is going to be an even more important piece of the transportation infrastructure, and a lot of the supply is being met by the TNC companies and other specific smaller startups that are forming just to serve that market.
Got it. And kind of related to that, there's a question that just came in, I think that's building on that, and with the changes that have come with COVID-19 and these local partnerships becoming irrelevant, what about the role of religious and other local community organizations that have been filling some of the transportation void, getting groceries, helping out seniors and disabled folks? Do you see this as a short-term or long-term trend? And have you studied any of the partnerships and their future role in helping people not only during this current healthcare crisis, but into the future?
I struggle with this one because I have a lot of colleagues who are very much in favor of these smaller community-based nonprofit solutions. I think they're very difficult to sustain long-term. I know volunteer driving is, it's something that sounds wonderful, but in the experience that I've had working at an area agency on aging, administering FTA dollars to some of those nonprofits, they are a great but usually very small scale solution. They tend to be still based on very much pen and paper and, personal relationships. And they tend to have a very small reach. I think they are important in certainly rural areas and with some populations. And I think there's also mutual aid networks which have been formed. I think they're more important in terms of mental health and social cohesion in general than as a viable transportation solution.
Got it. So another question here, the participant is a planner at a local health department, and they sometimes struggle to convince people that there's a reason to include health as a focus in city plans. as is it kind of fits in with development, economic development, sustainability, et cetera, et cetera. What rationale can planners at health organization use to plan for health specifically?
I have definitely been there. I remember when I was on the other side as a transportation planner in the city of Tupelo, Mississippi, trying to get the health department to come to some of my Complete Streets meetings, and I could tell they were like, why are you calling us about this thing you're doing with bikes and walking? Personally, I look to the arguments that elected officials have made in campaigns or things that seem to be of great community interest, and I use that as my argument. Honestly, the reason that I got into public health was because I really liked biking. I moved to Tupelo, Mississippi. The mayor was elected on a public health platform, and I thought if I explain why this is related to public health, maybe he'll let me do what I want. And that happened. If I had been in a place where environmental sustainability was really compelling, I would have tried to link my argument to that. So I would say use the argument that seems to be popular in the place where you live, and just keep trying different people. If one person in a department doesn't work, try a different person, try a different department, try a city council member or their policy advisor, and just keep trying until you get some traction somewhere.
That's great advice. Related to that, I think it's obvious that there's a lot of transportation professionals, I think across the board that need to learn about public health, not just the transportation component, but public health broadly. What do you think are the most important things about transportation that public health professionals still need to learn?
I think one thing that's important to know is that we use different jargon, but we're frequently trying to do the same thing. So in transportation, we might talk about transportation disadvantaged communities. We might look at individual neighborhoods. We might think about geographies that were negatively impacted by things like where did we choose to build the interstate, who is affected by air quality from the freeways that we have. And we're going to think about populations that have been made vulnerable by systemic transportation policies that we have. And if we go to our public health colleagues, they're going to be talking about social determinants of health and vulnerable populations, and they will talk more explicitly usually about race-based and policies that have affected people of color in different vulnerable communities. But we're really talking about, I think, the same thing, which is that we have a built environment and different policy infrastructure that has underinvested in particular communities, and a lot of us are trying to fix those systemic issues. We're just using different words, and we might have different approaches. So I think that getting a framework for some of that jargon, like social determinants of health, that's in the paper, to me is helpful to understand that there are some foundational principles that lie across all of the work that we're doing in our various public agencies, and that we can actually start to move the needle by doing more collaboration and thinking a little differently.
Got it. So a couple questions here on Medicaid and EMT. What do you consider best practices for ensuring that community transportation resources and NEMT resources are complementary?
I personally feel that the best way to start to build some of those collaborations and coordination is that the transportation agencies just need to align with Medicaid as well as they can. So the budgets for these services kind of demonstrate why it's been so challenging, I think, to get Medicaid to the table. So they spend about 0.5% of their budget on Medicaid, and that's $3 billion. So they tend not to be that motivated to spend a lot of time and effort improving 0.5% of what they're spending, right? Whereas if you look at the total budget of FTA, which is both capital and operations, it's $12 billion. So the amount of money that's being spent on Medicaid, it just really outpaces what we spend on rural transit or coordinated transportation. And I know, for instance, where I live in the state of Georgia, because state agencies tend to manage those, we have what looks like the same service to anyone that sees the vehicle, but it's run by 3 different agencies with 3 different regulatory environments and 3 different software platforms to schedule and dispatch and invoice for the trips. And it's very difficult to do any sort of coordination when you have that system in place. So my recommendation would be do the best you can to do everything the same the way Medicaid is run in your state. And unfortunately, there's 7 different Medicaid systems. It's a very complex beast in different states in the US. And I also feel that there was the Deficit Reduction Act of 2005 that highly incentivized a brokerage system, which means that you have like one brokerage and a lot of sort of mom and pop people running vehicles on the ground. But there are also a number of places where a United Healthcare or another Medicaid insurer runs the program themselves, or at least through their own broker. And I feel like if you give the insurer the control over the service and the performance and how they pay for it, you will get a better outcome because it will be easier for them to see why the quality of the service and the access to the service matters to the healthcare that they are providing for their patients. So I have more about those recommendations in the paper, but that's my brief overview. And Medicaid is a really challenging beast to figure out. So it's
Sure.
hard.
And there's a bunch of questions about it, and I think some of the readers were surprised to learn the kind of scope and scale of NEMT and kind of all of that it's involved. But one commenter here says that it's a mode or service that isn't really discussed in traditional planning documents. So, and you kind of alluded to this in your last question, but I'd like to go into it a little bit, or your last answer, but I'd like to go into it a little bit further. What ideas do you have to make NEMT and these kind of partnerships more in the minds and in the reports of urban planners and transportation planners broadly?
I think one of the things that's important to think about is how within transportation, we need to focus more on the system as a whole. I know, for instance, when I worked in actual human service transportation, we would talk about how, lack of sidewalks or lack of accessible sidewalks or, a major intersection would be a barrier to a trip. But it was hard for us to build relationships with the transit agency or to actually have collaboration across, the local, city that might actually be, have a sidewalk fund, the part of the MPO that's actually making decisions about project prioritization for state transportation dollars. I think to me, just knowing how much money is spent on Medicaid transportation compared with the other subsidized transportation modes, and yet how that's just 0.5% of all of the healthcare costs. I think that illustrates how much transportation is really a means to an end. We're providing a service, we're providing an infrastructure that we hope means that everyone can access essential services and meet all their daily needs of life and, actually have some choices in how they travel. But a lot of times in our day-to-day work, I don't know that we're really thinking that broadly about what it means to be a transportation planner or to be actually providing transportation services.
Got it. You mentioned sidewalks and you've mentioned biking a couple times, and that's prompted quite a few questions. So
Okay.
can you just talk a little bit about, especially since biking and walking are up significantly during the pandemic. It seems to be a mode of choice for people. There are obviously health impacts related to both of those, but our infrastructure for sidewalks is not always safe. Infrastructure for biking is not always complete. What role does biking and walking have after the pandemic, and what are some things that we can be putting in place now to be sure that the positive health outcomes of those modes are incorporated into future plans?
So a lot of people may have heard this example, especially if you've heard me talk before I love it, because I love it. But the Nashville Metropolitan Planning Organization, probably about a decade ago, they changed their project prioritization point system, and they wanted to prioritize complete streets. And so if you had bike or walking facilities, you would get a higher score and you'd be more likely to get funded. So they basically went from 2% to 70%, I think, in a year of development or redevelopment projects that had a bike or a pedestrian component to it. So I think that sort of small p policy or administrative change can have really significant impacts, and we need to be doing that redevelopment on our local and collector and arterial roads. Most of the people on this call are probably familiar with the demographic changes that we're going to be seeing as we have a higher proportion of older adults in the community, and on average, you will outlive your ability to drive by about 10 years. And when we think about where older adults are living, most of them are living in single-use suburbs that it's going to be very difficult to run transit through. So thinking more broadly about what a transportation network looks like and how we provide multimodal access, even at the suburban and the small community level, I think is going to be really important in the long term, so that when people outlive their ability to drive, they do not become trapped in their homes unless they happen to be able to get on the waiting list and eventually get access to a trip, because demand is already outpacing supply for subsidized transportation. And as the proportion of older adults grows, the problem, I think, is going to get worse.
Got it. So I've got a couple of questions that have come in about TNCs and TNC partnerships with healthcare providers, hospitals, et cetera. Can you talk a little bit more in detail about the role of TNCs in this? And then, certainly there's some potential benefits. There's also some concerns from folks, including regulation, training for drivers, and some of those kind of things. And how would public policy address some of those concerns?
Sure. I think TNCs, like the scooters, there was an unmet demand for the service they provide, which was the user experience focus of, putting up the app, scheduling the trip, knowing in advance how much it's going to cost, getting out of the vehicle, going about your day. I think what's difficult is to compare Uber and Lyft to traditional name it providers or paratransit or other services. Part of that is because we don't really know the true cost of a TNC trip because they've been subsidized by venture capital to such a large extent for so long. I think that's starting to go away, but I don't know that it's completely away. So even if you were to do a cost comparison, you're leaving out a lot because of the nature of TNCs not being considered employees. I think in some cases now, a few of them, Uber Health is HIPAA compliant, but there's a lot of regulation put on top of drivers in the more traditional paratransit or rural transit or name it market. And there are safeguards in place in terms of, liabilities and background checks, as well as things like patient protection through HIPAA for those services. I think there's opportunity to take the best of each and collaborate and create a service that actually serves people better and is still more convenient. So there's a lot to like about the TNCs, but I think there is a lot of expertise and value and benefit to the traditional services that I think is getting overlooked by the shininess of some of the TNC benefits.
Got it. And I guess related to that, talking about the shiny new things, a couple questions about future technologies, connected automated vehicles, ITS systems, drones. What role do you think that those technologies have in healthcare and health and transportation today? And then how should we be thinking about them, anticipating, planning for them in the future?
So I think I'm actually more pro drone than almost anything else, because it actually seems like a reasonably developed technology that we're likely to see in wide use in the near future. I think especially when you compare it to something like autonomous vehicles. I think there is a tremendous benefit to coordination of the sort of trip scheduling and software technology across these subsidized trips. I think there's a lot of opportunity with the technology there. I think there's a lot of opportunity with telehealth technology, although there is such a divide in Wi-Fi access in rural areas, and that's where a lot, the population tends to be older and poor and in worse health. So that's going to continue to be a barrier, just actually having internet access. But I feel like drones are actually going to be pretty beneficial because of the grocery delivery or medical delivery or other sorts of even more, immediate things like, can they keep your milk cold, more than maybe a traditional transportation service if you were to get grocery delivery that way. I actually went into technology because I inherited a technology project that my leadership thought was going to fix a problem that it really did not and could not. And I felt as though there was a ton of money being spent in technology, but the people that I saw working in it didn't necessarily come from a background to understand access barriers and, what is the user experience? Like, who is the user? What are all the barriers and needs that different kinds of populations have? And I felt that it was really important for the people working in technology to have a better understanding of all the different kinds of customer that they could have and to build solutions that would actually work for people. And I think one reason I'm a little pessimistic about autonomous vehicles is because I don't think there's a lot of thought being put into that by the folks that have the most power and influence in that part of transportation technology.
Got it. I think in your last answer you alluded to this, but another question is, beyond the traditional healthcare destinations, whether it's through new technologies or existing ones, how do we think about access to alternative, or not alternative, but different types of health-related destinations, such as food access, parks and recreation, those kind of things? How do we plan for that?
I think one of the best ways to understand how to do that planning is by having local relationships. So for instance, if the folks on this call are familiar with the untokening, it's a mobility justice initiative, and a few of the things they talk about are things like, the best practices that we're used to may not apply at a local level. You need to go into the different communities that you're planning for and talk to those people, ask them what they need, and then do the things that they tell you. So for instance, I would say, in Atlanta, we have the Atlanta Beltline, and it's something that it's the pedestrian and bike network, and it connects 45 neighborhoods and 22 miles around Atlanta. And I think there was not as much planning and outreach to some of the lower income and Black communities near the Beltline, and so the person that you see using it usually reflects a more upper class and white demographic, and that some of that is because in the planning stages, there wasn't as much of a focus on everybody that lives in a place, where they want to go. Is this a method that they will use to get them there? And so I think doing a better job of listening to folks in the community is important. And that's also something that I felt like my colleagues when I worked in public health had more expertise in doing. That was one of the things that was best about working with them, was the cultural competency that they brought to doing their work and understanding how to do it.
Great. So we are at 45 minutes past the hour, and we're pretty much out of time. Luckily, we've been able to go through most of the questions, and I really appreciate everyone that's been on the phone that have been submitting these. It's really been a valuable conversation. Before we close, Renee, anything that you'd like to add or kind of conclude with, and kind of closing remarks before we sign off?
No, I don't think so. I just appreciate everybody's time, and I enjoyed this conversation.
Great. Yes. So I encourage folks to visit our website, www.enotrans.org, download the paper, and please continue to engage on this. This is we hope this to be a continuing conversation here at Eno with Renee and with everyone else that's been participating. It's obviously hugely important now with COVID, but as Renee noted, this has always been an issue and needs to be a front and center piece of our transportation planning and system. So thanks everyone for joining. We will be sending a recording of this around in a few hours. And Renee, thank you so much for your time and for contributing to this conversation here at Eno.
Thanks, Paul. Thanks, everyone.
All right, have a nice afternoon, everybody.